Welcome to the health ecosystem. This is our final session of the conference, and to kick it off, I wanted to remind you of something that Alan Guttmacher started the conference with. One of the challenges he gave us, one of the key challenges, was that we should improving children's well-being should be our goal, not merely improving children's health. And that fits really well with the theme of this session on the health ecosystem. We wanted to make sure we included this session to really highlight the social, the educational, the economic, the political, the cultural, and the environmental factors that influence children's health and well-being. So to do that, we put together, I think, a really fascinating and intriguing panel. A lot of biomedical research really focuses on things that are beneath the skin, inside of us. In contrast, this panel is going to focus a lot more on things that are outside the skin and affect us, often very profoundly. An example I like to give relates to my own field in childhood obesity, in that if you're a child who grows up in East Palo Alto, or just on the other side of 101, you're 2 or 3 times more likely to be obese than if you grow up on this side of 101, just 2 miles away. Now that's clearly not because everyone who has a mutation in their leptin gene decided to move from this side of 101 to that side of 101. There are a lot of other factors involved, and that's really what the health ecosystem is all about. And that's why in public health circles, you often hear people say that your zip code is more important than your genetic code in terms of determining your health and your well-being. So, to kick off the health ecosystem panel, we have a wonderful keynote from Dr. Don Schwarz. Don joins us from the Robert Wood Johnson Foundation, where he directs their efforts to catalyze public demand for healthier people and healthier places to live, learn, work, and play. So thinking about that, catalyzing demand in the community for healthier places and healthier people. In doing so, he leads an effort to identify, support, and spread the word about policies and approaches that promote lifelong health for all Americans. He's a distinguished leader in public health, and before joining the foundation, he was Deputy Mayor for Health and Opportunity and Health Commissioner for the City of Philadelphia. And that followed a distinguished career, more familiar to us, in academic pediatrics at the University of Pennsylvania and Children's Hospital of Philadelphia. So I'd like to welcome Don.
Good morning, everybody, and thank you, Tom. It is my great pleasure to be here. I have to say the conference to date has been remarkable, and I think the conversation has been rich. I came to today, as you heard, through a series of steps. My first step was as a practicing pediatrician, and I practiced with teenagers and their infants. And the story that motivated my change, I think, and my progress from that role to my current position has to do with the infant of a teenage mother. The mother was 15 when she gave birth. It was her second child. And I received this baby after a 3-month stay in the neonatal intensive care unit with the child's grandmother. And the infant was brought in by this woman, gray-haired, slightly hunched, who had an apnea monitor at that time. I'm sort of a dinosaur from the old days. This electronic monitor and an oxygen supply and other things. And she was, I guess I would say, hopeless. And we chatted a bit about the care for this baby. And it was clear that this infant was no normal infant. This was an infant who had had a very complicated stay in the nursery, who had follow-up appointments with 6 different physicians, who had home visitors who were supposed to come and visit this family at the time of discharge. And the 38-year-old grandmother was completely overwhelmed because she couldn't figure out how to coordinate those visits with the family who had just moved to a shelter from their home. And I, as the pediatrician, looked at this family and said to myself, I am not capable either of managing the care of this infant. And yet, think of the resources that have gone into the creation of this situation. And think of how narrowly we have thought about this particular family unit. If we think about child health, and as Tom said, well-being, we all know that there are a series of inputs into what makes a healthy child. While we focus often on the issue of services, and we focus often on biology, what I would say to you is, without a partnership among the various parts of the ecosystem that make a healthy child, we're not going to have healthy children. We often look at it from our perch with a narrow focus on a number of partners who are critical to the wonderful things that we can do for individual children. But what I want to do is say that many of the issues that we have to deal with and that families deal with and that complicate what seem often in the laboratory as simple issues, those issues aren't simple, and they're not going to be solved, they're not going to be addressed, and they're not being addressed by what we see as a health care ecosystem. In this country, though, we spend, as everybody knows, lots of money on healthcare. We spend, depending on what country we're comparing ourselves to, 2, 3, or more times what other nations spend. And yet, the way we spend is quite different. If we look at our health outcomes in this country compared to other nations, and we look at our total spend, not just on health care, but on social services and supports, we are woefully behind in the social service supports that lead to health in other nations. As we develop an increasingly complex healthcare system in this country, and we are able to do miracles for children throughout the nation, what we have to realize is we need to build out the rest of the system. And I think we all, as people who deal with children and families and care, recognize that. The question is, what's the path forward? We, in fact, spend 55 cents on the dollar spent on healthcare, where other nations spend $2 for social services compared to healthcare. And we know that in those countries, that spending ratio correlates with lower infant mortality rates, lower low birth weight rates, lower rates of premature birth in general, and longer life expectancy. So we could talk, instead of a health care ecosystem, about a health ecosystem in which healthcare is a vital component. But the other components have to work together with health, as I think we all recognize. And shift, for instance, our view from our own area of this ecosystem to other areas of the ecosystem, such as education. When we think about children and education in this country, what we know is that education not only correlates, but predicts health in many cases. We know that a high school degree, as you see on this graph, makes an enormous difference to life expectancy. And you see the step off. But also, at every point on this graph, more education is associated with lower risk of premature death. So living longer is associated with better education. And one way to look at it that is particularly painful, here you see a graph, excuse me, that shows education by time, by death per 100,000. And what you see on the top line is that over time, those with less education in this country have had higher and higher rates of early death. And those with more education have, in fact, enjoyed longer lives. So it's not that everyone's getting better, it's that those who are getting better enjoy the benefit of more education. Another way to look at this is on the panel to your left. You see those with less high school and those on the right with those who are college graduates. And you see that for the gender and racial groups mentioned, in every case, if folks have less education, their life expectancy is getting worse, and those who have more education are having better and better longer lives. So we have a divide in terms of education in this country. And while our narrative overall is one of increasing life expectancy, a substantial part of the population isn't benefiting from all of the care that we give because of other factors within the health ecosystem. And in this country, during the last few years of the recession, what we see is that we have in fact made the divide in terms of how we're prioritizing and spending worse. So yes, we spend more per person on healthcare than any other Western nation. We spend more now than we did 5 years ago per person on healthcare. And in fact, even before the expansion with the Affordable Care Act, we decided during the recession to continue to spend more disproportionately on health and less on early education. We know that if we invest early in a child's life, not just in health care, but across the spectrum, we will get a higher return on our investment. The R line here on the graph that you see represents a return on investment of $1 back for every $1 we put in. If we as a nation want to get our money's worth out of people, we need to invest early, and particularly early in education. But in fact, compared to other Western nations, we're not doing that. If we think about how we are investing, we're investing in healthcare, but we're not investing in education or social services the way that the rest of the world is. So, if I think about it in a model, what I see is that for a child, there are influences throughout life. And as we've talked about, every child comes in with a genome and genetic programming. But we know that environment affects at many points throughout the life of that person, their health trajectory. This illustrates, as you see the circles, that a child who is not exposed to bad things generally does better than a child who is exposed to bad things. And once exposed, that child may go on to have an illness. We think of it as primary, secondary, and tertiary prevention. But the more upstream we get, the closer we get to the birth of that child, or even before the birth of that child, in terms of protecting that child with good environments and bringing all the systems together to have positive impacts on that child and family, the more likely we are to have a healthy child. So if we think about the health ecosystem, I think we're all probably more comfortable on the right side of that ecosystem, working with families, perhaps working even with the press, knowing about education. What the next phase of my life after I left academe and went to work in government taught me was about that other side of this, the left side of this panel. That is, what happens between government and community development and investment that can actually make a difference to the environments in which children live and have positive impacts then on those children. As a pediatrician, it seemed impossible. As a pediatrician, I looked out from my office and said, wow, I can tell parents about not feeding their child wrong. I can make sure that this infant gets prescriptions for medications. But what can I do about housing? What can I do about food that's available and hunger? Not a whole lot other than voting, perhaps. But as Tom mentioned, what we know is that zip code makes a big difference to health. This is a graph showing a picture showing the average life expectancy for people by zip code around our nation's capital. And what you see is that there's a 7-year difference in life expectancy for people living outside Washington versus those who are living inside Washington. In Philadelphia, where I come from, the environment isn't necessarily a healthy one. Philadelphia is the poorest of the 10 largest cities in the country. And when I went on to be deputy mayor in the city, I was very much aware that the environment was not one that was health promoting. Not only did we have competition in the advertising and media environment, but we did stupid things in terms of construction, like tell people to walk, and we built light poles in the middle of where they might want to walk. I don't know if that happens in California, but it happens in Pennsylvania. And I became aware that there were natural experiments that had happened that showed that small differences and changes in the physical environment made a real difference to problems that were really hard for me to address and think about in the clinical environment. This is something that I find fascinating. It shows the impact of the change to what's called easy pass, Do you have Easy Pass in California? Easy Pass is a little thing that goes on your car for toll roads. That means you don't have to stop at a toll booth. You can drive through, and it electronically, technology, clicks you off and you pay your toll electronically. Well, in New Jersey, the famous New Jersey Turnpike was full, and still is, of toll booths. And the Pennsylvania Turnpike is filled with toll booths. Freeways, we don't know so much back east. But what was found was that those people who lived near these toll booths and therefore were exposed to exhaust as cars and trucks idled at the toll booth tended to have higher rates of premature birth. And in fact, the further you lived from a toll booth, the less likely you were to have a premature birth. The state of New Jersey decided to look at this and studied, as you might imagine, about 150 correlates, such as poverty and ethnicity and type of housing and whether you had an air conditioner and so forth. And in a large-scale controlled study that looked before and after the initiation of Easy Pass, this drive-through, no idle at the toll booth system for collecting tolls, they in fact found that rates of low birth weight birth went down for those people who lived closer to a toll booth. A government intervention, not intended to make a difference specifically on premature birth or low birth weight birth, made actually a substantial contribution. Among families within 2 kilometers of the expressway toll booths, premature births fell between 6.7 and 9.2%. I don't know how many of you work on issues of low birth weight birth, for instance, but we all know that across the country, low birth weight birth rates have not changed substantially in 50 years. It's very hard to have an impact on low birth weight birth. But the incidence of low birth weight fell between 8.5 and 11.3%, depending on the car volume going through the particular toll booth. Reducing traffic congestion makes a difference to pollution, documented actually at the toll booths in New Jersey and Pennsylvania before and after Easy Pass, and the particulate matter and NO2 in particular concentration directly correlated with what happened in terms of premature birth. In Philadelphia, we created something called Get Healthy Philly. The question was, how could we make it easier for people to engage in healthy behavior? So give people the opportunity to live healthy lives and have their children live healthier lives. We took neighborhoods in Philadelphia, and using big data that were available to us, we looked at every single housing unit and mapped the distance between the housing unit and where fresh food was sold. We knew that from receipts for sales tax for the city. So we mapped how far would it be as a walk from where you live to where you could get fresh food. And we put that on a map. And we showed it around the city. And people were astounded how difficult it was for families in this particular neighborhood, which is one of the poorest in Philadelphia, to access fresh food. In fact, in this neighborhood, when we took carrots to children and potatoes to children who were 5 years old and asked them what they were, a third of the children couldn't name the 2 vegetables. They knew French fries. 2 years later, the green areas show areas where we brought fresh food into the neighborhood. Bodegas and corner stores, 1 out of every 4 bodegas and corner stores in Philadelphia now sells fresh produce. I don't know California, but I can tell you it's a revolution in Pennsylvania. Supermarkets are now moving into this community. We have shown that there is a sustainable business model for selling produce close to people's homes. And in fact, 61,000 fewer Philadelphians now who are in low-income neighborhoods have access to healthy food. That means their children have access to healthy food. This is a map of the city of Philadelphia. Each dot represents a point of intervention over a 4-year period. Those interventions included bikes and walking paths, corner stores, supermarkets, recreation centers that now have healthy food and snacks for children, after-school programs that have exercise programs, and we took on smoking because it's clear that if we want to make a difference to the outcomes related to obesity and heart disease, we also have to think of the cofactor related to smoking. And so you also see retail outlets that either stopped selling cigarettes or where we had interventions for them to begin promoting people to access smoking cessation. And it made a difference. Rates of childhood obesity are down in Philadelphia, and in fact, the rate of reduction, particularly among minority children, is the highest in the country across all of the racial and ethnic groups shown. And for adults, we were the first city in the country to show that adult obesity rates could not only level off, but begin to come down. And for smoking, with advertising and promoting, we increased the use of the quit line. In fact, we found that just calling the quit line and getting nicotine replacement therapy was the lowest cost, most effective way to help people quit. 37% of people who called the quit line were still quit 6 months later. And this is what happened to smoking. The largest decrease in smoking over a 4-year period of any large city in the country. So, what we did using this model is we said the environment in which you live is important. We want to make sure the exposures are positive and not negative. We want to make sure they're positive not only for people who don't have illness or haven't been exposed to something bad, but for everybody. But if you've been exposed to illness, if you're a family where your child's diet is critically important, we want you to be able to access fresh and healthy food. So your child can now have the connection between health care and good food. If physical activity is important, we want to make sure that your child has access to the ability to exercise. If smoking is bad and children have asthma, we want to make sure that children aren't exposed in their home environment to cigarette smoke. So public housing in Philadelphia is now smoke-free. How do we pay for this long-term is the question that I've most often been asked. And I think we have a real challenge. If you think it's hard to pay for healthcare technology, let me tell you, paying for changing home environments in this country is virtually impossible. And paying for the kinds of interventions that you may launch in your clinical settings to make a difference to the environments for children, the social environments and the physical environments, paying for them after the initial phase is very hard. We don't have big companies willing to invest in social intervention. But people are innovating. So hopefully you've all heard about pay for success. There are now models that say, if we have social interventions that have been shown to have positive outcomes, we should be able to monetize those positive outcomes and invest in them. And if government won't invest up front because the cost seems too high, maybe banks and venture capitalists will. And in fact, it's happening. So, with healthcare funding sources decreasing, markets are shifting to this idea of paying for success. And a critical part of it is, if we're going to do these models at large enough scale, we need big data on board, and we need expertise in measurement, sophisticated measurement, so that investors are sure that they're getting their money's worth. Here are a number of areas where people are now already investing in what's called pay for success. And I'm going to highlight the first one on the list. You may have heard of the Nurse-Family Partnership. It's a program that now is evidence-based, data-driven, been used in many parts of the country, in fact in all 50 states, where nurse visitors go to see children, go to mothers while they're pregnant, and then follow those mothers and their children for 2 years after the birth of the child. It's only for first children. It's only for a subset of mothers. But within that group of eligibles, what we know is money is saved over the life of that child. And if government were able to see the long-term return, government might put nurse-family partnership everywhere. But as you may know, governments tend to look in 2 to 4 to 6 year timelines. So it's very hard to get government to invest long-term in things like the Nurse-Family Partnership. But venture capitalists love it. So what's going on around the country now is a number of large-scale trials at scale where venture capital is coming in to say to government, we'll pay the upfront costs and we'll take the risk. We think the nurse-family partnership has enough evidence that if we invest in it upfront and you, government, get the return later, you will pay us back. If there's no return, we lose our money. These experiments, because they're still experiments, I think hold tremendous promise in thinking about how we institutionalize social intervention in this country. There are a number of different areas where people are investing, as you see, but what we know is that this is still experimental. There are only a few experiments like this, and these experiments are critically dependent on being able to monetize the return. So, for my set of interventions in the city of Philadelphia, many interventions, many locations, all put together because of the complexity of the food environment and the complexity of the physical activity environment and what needs to change to encourage people to do that. We're not able to monetize a simple intervention, single intervention to a single output. So this kind of investing is critically important. It's not going to solve all the problems. What the Robert Wood Johnson Foundation, where I currently work, says is, what we need to do is we need to all together, the healthcare sector, social sectors, government, and others, we all need to come together and agree that we need to build a culture that promotes health in this country. The foundation brought together experts from across a series of fields to think about what are the 3 big bets that we have to invest in as a foundation, the largest foundation that invests in health in the world. And what we've said is, 1, we have to invest in young children in particular, and specifically we have to invest in early education. Children have to be in healthy environments before they get to school. And we have to fundamentally change how we revitalize neighborhoods. We have to integrate health into community development. $60 billion a year goes into rebuilding poor neighborhoods in this country. And when those neighborhoods are rebuilt, rarely is health in the front of anyone's mind. And yet, if we build a child care center with a solid concrete floor, we know children will be injured. If we build a child care center with carpets, we know that children with asthma are going to have a harder time. If we build a child care center with high sinks, we know the rate of back injury in those who work at those child care centers is going to be high, and we know that the children in the centers are not going to drink water, they're going to drink sugary beverages. So how we build the environment, particularly for poor children in this country, makes an enormous difference. And the foundation is investing in a partnership with those who create communities in this country to say, let's make communities that are healthy for people. And finally, we need to broaden the mindset, mission, and incentives for health professionals and healthcare institutions from treating illness and helping people lead healthy lives, which is, I hope, what we're all talking about. You are investing in ways to make people's lives healthier. It may be a subset of the population, it may be a larger set of the population, depending on the kinds of interventions and the specific areas of your work. But your work is going to be better and more impactful if we all work together to promote health and well-being, not just fix disease. So, we look forward to working with you to build a culture of health in this country. And I look forward to never again hearing stories about premature infants and vulnerable children who have benefited magnificently from the kinds of medical interventions that we can put together. I look forward to never hearing that the money we spend on those medical interventions goes to naught when children go home to hostile environments. We need to build healthy environments so that all of our children and all of our families can have the opportunity to live healthy lives. Thank you.